Good afternoon. My name is Dr. Clement, and I would like to say something about the manifestations of poliomyelitis. How do you see that this is poliomyelitis? It's not any other condition. There are only three patterns that one has to look at. That is non-clinical, or in fact subclinical, and or sometimes is called inapparent poliomyelitis. And then number two is abortive poliomyelitis. Number three, you have the major poliomyelitis. Can I say something about the inapparent poliomyelitis? It constitutes about 95% of all poliovirus infections. And then the abortive poliomyelitis constitutes about 4 to 8% of all poliovirus infections. And then one needs to know, how do you club them together? That is poliomyelitis, subclinical and abortive. They tend to go unnoticed. Though you can still say something about abortive poliomyelitis, they go unnoticed, and so that's why we're not serious about them. We're serious about major poliomyelitis. I'm still going to talk about that, but how do you say this is abortive poliomyelitis? Say that because these patients, they present with a headache, slight fever, headache, and pharyngitis, the inflammation of the pharynx. Malaise, these patients are sickly, and they are not well. You look at the patient, is not well. Malaise. The patient has got a sore throat. The patient has got, because of the pharyngitis or the inflammation of the pharynx, they get vomiting. But this will go on for something like 72 hours and it's gone. It's gone after 72 hours. Everything is gone. And so that's why these two, they tend to go unnoticed. Nobody worries about them. But the major poliomyelitis has got a characteristic feature very different from the inapparent and abortive. This one, the poliovirus tends to attack the central nervous system, and this is unfortunate. In children, it tends to have a biphasic course, follows the biphasic course. When the slight or when the minor illness is recovering, then it switches over to the major illness or the major poliomyelitis. So there's that biphasic nature in children, that biphasic nature, the recovery of minor illness giving rise to the major poliomyelitis. Men, the most important factor to be considered with this poliomyelitis, this major poliomyelitis, is the fact that it is divided into two, non-paralytic and paralytic. And non-paralytic, what do you say about non-paralytic? How do you club them together, first of all? That is non-paralytic and paralytic, to say that this is just major. What is it? There's something noticeable. There's resistance to the flexion of the neck. Resistance to flexion of the neck. That's the main thing to be noticed. And you get it in non-paralytic and paralytic. You get that. So that's why we say we club them together with that. And they also have what is known as tripod. Tripod, when they try to support themselves when sitting up, they extend their arms to the back to try and, they form a tripod, so to say. The body goes up, and then these two hands go, that forms a tripod. It's called tripoding. They tripod. This happens to both, that is non-paralytic and paralytic, right? They tripod. And when they are lying in the supine position, they tend to, the head falls back. The head falls back. And then the shoulders are raised, are elevated. And when they are in that supine position, they can't elevate the legs to a 90 degrees angle. No, they can't. They won't be able to do that. Then you know that I'm dealing with non-paralytic and paralytic. They tend to do that. To cross the line, if there's a positive Brzezinski, positive Brzezinski, how do you see that? How do you see that? Because we normally talk about positive Brzezinski in meningitis. What is that? What is that? When you lift the head up, the patient is in a supine position and you lift the head up. First of all, there is resistance, and the knees will be bent, will be flexed, so to say. Bent, flexed. In other words, they can't be elongated. They'll be flexed. They'll be flexed. Once there's a flexion of the knees, when you try to lift up the head, and then there's a flexion of the then that's a positive Brzezinski sign. The first person to see was Brzezinski. The first person to see that, to notice that when you lift the head up, the knees will be bent, or in other words, flexed. So that's a positive. But if you try to elongate those flexed legs, you try to elongate, now you want the leg to be elongated. In other words, you're straightening the leg. Remember, it was flexed. Now you're straightening it. You are extending it. There's going to be resistance. That is known as a positive Koenig sign. Those two, they suggest, we normally say, oh, the patient has got meningitis, that kind of thing. No. Now you find it with a paralytic poliomyelitis. That's why it is important now to be able to diagnose this. When you're diagnosing it, you always watch out. You should not think that this is an ecovirus or a Coxsackie virus. Those are enteroviruses. Remember the three enteroviruses: Coxsackie virus, ecovirus, and poliovirus. So they share the same location. So it's easy to think that it is the other two, ecovirus but if you isolate the poliovirus, that's perfect. Then you know that I'm dealing with paralytic poliomyelitis because I've got a positive Brzezinski sign and I've got a positive Koenig sign. And this is not meningitis. This is not meningitis. This is a major paralytic poliomyelitis. I would like to go back just a little bit to non-paralytic poliomyelitis. Because how do you say this is non-paralytic poliomyelitis as opposed, because if you use fever, for instance, as a standard, fever, we had a slight fever with abortive poliomyelitis, right? After 72 hours, it was gone. You had a slight fever. But now you have a moderate fever. A moderate, considerable fever. You need to notice this because the temperature is rocketing. So there's a moderate fever. So moderate fever. So what else do you notice with non-paralytic? I also noticed that I still have the headache. I still have the headache. The patient is still having vomiting. Because of course, you know, the oropharynx, once it's affected, vomiting, still having vomiting. But now in addition to that, there's lethargy. Lethargy. Patient is lethargic. No energy, patient going down, no energy, lethargic. And irritability. The patient, if you look at hypersensitivity to touch, the patient has got pains in the neck and the pains in the back, pains in the arms, pains in the legs, pains in the abdomen. Then you get worried. This is non-paralytic. In 1 week, this is gone. In 1 week, it takes 1 week for non-paralytic. In 1 week. But the meningeal irritation goes for something like 2 weeks. Meningeal irritation. Remember, we're talking about many, we're talking about the meninges and the so. Meninges, remember those membranes which cover the central nervous system, spinal cord and the brain, those meninges. So there's meningeal irritation, which takes something like 2 weeks. Then you get to paralytic. And astride to paralytic, it's when you cross the line now. You get to a positive Brzezinski sign, a positive Koenig sign. Then now you're in paralytic. And you get worried when you're in paralytic because if this paralytic poliomyelitis involves the first part of the brainstem, the medulla oblongata, now you can get, this is the brain we're talking about. You see, brainstem. Remember the spinal cord. We're talking about myelitis, poliomyelitis. This is the inflammation of the spinal cord. But as the spinal cord is going up, remember, what is important with this is to mark the lesion. Where is the lesion? Is it in the cervical area, that is the neck? Is it in the thorax? Or is it in the lumbar area? If it's in the lumbar area, oh, bad news. Bad news. Patient, the body won't be supported by this weak lumbar area. where the lesion is. It won't be, then the walking becomes so disorganized and clumsy. So the extent of paralysis is determined by the location of the lesion. Where's the lesion? Is it in cervical area, thorax, or the lumbar? Now, what we're saying is, if the poliomyelitis gets extended and it gets to the first part of the brainstem, the first part of the brainstem is the medulla oblongata. And the medulla oblongata, it controls areas like digestion. It controls areas like respiration. And this is, so if these are disturbed, it controls areas like swallowing. You know, if it involves the spinal cord, the medulla oblongata, then you can get encephalitis. You know, there's inflammation of the brain. Inflammation of the brain. This is an infection. It's an infection. It infects the brain. So if it infects the medulla oblongata, it's actually infecting the brain. That's the brainstem. That is the brainstem. Because remember, brainstem, it consists of the medulla oblongata, the pons, and then the midbrain. So it's right at the medulla oblongata. There in the medulla oblongata, what is important and to note are the cranial nerves. Because what it does, this is called a perilous poliomyelitis. Once it gets, it's called a bulbar poliomyelitis. And this is the most perilous, most dangerous because it's disturbing now the cranial nerves. It weakens the muscles which are innervated by the cranial nerves. It weakens them. What if it weakens? I mean, in particular, we've got the glossopharyngeal, which is one of the cranial nerves, the one that controls, parotid salivation. So the saliva is determined by this glossopharyngeal nerve, which innervates, the parotid gland. So the parotid encourages the parotid gland to actually release the saliva, so for swallowing to be possible. So swallowing is a problem because glossopharyngeal, the muscles are weakened. The muscles innervated by glossopharyngeal, they're weakened. And the muscles innervated by the vagus nerve, they're weakened. Vagus nerve has got its own problems. Has got its own functions, really. It's involved in swallowing. It is involved in swallowing. But in addition to that, it is also involved in the parasympathetic stimulation. Parasympathetic stimulation, if there are disturbances, there's going to be now what is known as a bradycardia, a slow heart rate. And when there's a slow heart rate, the brain is going to interpret this as it's not moving. The heart is failing because it's slow in beating, a bradycardia. It's failing. And if it is failing, what happens? Remember, the heart is supposed to pump blood to all the parts of the body. And now it is not pumping, it's like it's failing. So the blood that comes from the lungs through the pulmonary vein, which is the only vein that carries oxygenated blood, that vein is going to have a problem. When the blood gets to the heart, it's not pumped out. The heart is not receptive because it's beating slowly. It's not beating. So the blood will go back. And when it goes back to the lungs. It causes what is known as pulmonary edema. That pulmonary edema can be fatal. The patient can die from that, just from that. A fatal pulmonary edema because of the disturbance of the what? Of the vagus nerve. Vagus nerve is one of the cranial nerves, and it is being disturbed by this infection, by poliomyelitis. But this bulbar paralytic poliomyelitis. This is sad. And that happens. But again, there's another problem. Remember we said the vagus nerve controls swallowing. So swallowing is, if the vagus nerve is disturbed, swallowing is not going to be proper. Glossopharyngeal is also a cranial nerve that controls swallowing. So swallowing is not going to be proper. We are going to get what is known as dysphagia. Difficult swallowing. So now what's going to happen to the food? The food is going to be regurgitation of food through the nasal cavities. You know, the nasal passages. It's going to be regurgitation. If food goes through the nasal area, what is it disturbing? It's disturbing respiration. So there's going to be dyspnea. The patient is going to have dyspnea. Because the patient won't be able to, there's going to be difficult breathing. So and there's going to be abnormal respiratory rate. The respiratory rate is not going to be normal because there's food in the passages, in the nasal passages. There's going to be disturbance. There's going to be abnormal respiratory rate. There's going to be abnormal depth of respiration. There's going to be abnormal depth. There's going to be abnormal rhythm of respiration. And this will give rise to what? It will give rise to respiratory arrest. The patient dies from that. The patient dies from that. That's why they call this a perilous, a very dangerous, this paralytic poliomyelitis. It can cause problems like paralytic ileus. Paralytic ileus, you've got a small intestine that is just not functioning. In other words, remember, there must be peristalsis, there must be movement of food or movement of stools going down. There's nothing to pump there. There's what is known as paralytic ileus because of this. So there's going to be constipation. If there's constipation, there's going to be a distended abdomen. There's constipation. There's going to, because of everything is stuck, there's going to be urine retention. There's going to be urolithiasis because of the problems. The vagus nerve is not doing what it's supposed to do, really. Everything is stuck. The respiration this side is stuck. The heart this side. There's going to be myocarditis, inflammation of the myocardium. There's going to be cor pulmonale. Is the failure of the right side of the heart. This is a problem. This is a problem. So this is what we have with paralytic. Paralytic poliomyelitis is a killer. From the respiratory side, respiratory arrest. From the heart side, there's going to be pulmonary edema, fatal pulmonary edema. There's going to be, once the respiratory muscles fail, what do you expect? You're going to get what is known as lung collapse, atelectasis. You're going to have pneumonia, inflammation, infection of the lungs. It's easy to get that because everything is stuck. This is a problem. We are worried about this. This is one condition that people have to worry about.